Jake has been gradually losing his sight since birth, but no longer thanks to a groundbreaking gene therapy.
Just being able to see facial features on my own face is something that I never used to be able to do.
Jake from County Durham has a rare inherited condition, which means his central vision is largely a blur. Since his right eye was treated a year ago, his peripheral vision has improved.
I'm in the best place I've probably been in 24 years of life. Last year, for a lot of people, was a dark, miserable year. For me, it was probably easily the best year of my life.
After a year's delay due to COVID, Jake has now had his other eye treated at Moorfields Eye Hospital in London, which it's hoped may further stabilise and perhaps improve his vision. The one-off gene therapy called Lux Turner is delivered via injection. It costs £600,000, but the NHS has agreed a discounted price with the manufacturer Novartis. The injection delivers working copies of a faulty gene, RPE65, into the retina at the back of the eye. The DNA is encased in a harmless virus which breaks into the retinal cells. Once inside the nucleus, the replacement gene kickstarts production of the RPE65 protein, essential for healthy vision.
This is really transformational. It provides an opportunity, provides hope for people, not only with this specific condition, but people with other similar conditions hope that they can protect their sight in the long term.
I keep noticing subtle improvements. I noticed one today coming into this park. I noticed that there are railings.
Right. Assalamu alaikum everybody again. So what did you notice in the video? This is going to be a very interactive session, so be vigilant. I'm going to ask you questions and hopefully we will learn along the way. So the first thing is that this is talking about gene therapy for retinal dystrophy. Okay, one of the FDA approved gene therapy. Number two, which gene were they talking about?
RPE65.
Yes. Okay, so it's very important that you don't look at a patient and say, well, you have retinitis pigmentosa, there's a treatment available. No, you cannot tell this patient anymore. You have to look for specific genetic mutations. So we are going to discuss a couple of cases here, and the reason to do this is to sort of explore what are the options available to patients, what are the diagnoses, and how some of the diagnoses which phenotypically look similar are quite different. These are my disclosures. AI Diagnostic is a AI company not related to this talk. Right, so this is the first case. 6-year-old male child complaining of decreased vision since 1.5 months. Birth history was C-section, full term, 2 days in an ICU, no extra oxygen, developmental milestones achieved on time, and he had a sister who was 2 years old, and very difficult to get accurate history of vision from her sister. So this is a family tree, and this is the examination. So other than his vision, everything else was within the normal range. So this is the fundus examination. This is the right eye. This is the left eye, and these are the enlarged images of right and left eye. Right. यहाँ के lights dim कर दें please. So basically, anybody would want to comment on what's going on? ये lights सब dim कर दें ताकि अच्छा नजर आए. ना इधर होती हैं पीछे बटन दबा के. Anyway, so what are we seeing here? Anybody want to comment?
Beetle bronze.
Yes, okay, so beetle bronze appearance of the fundus. वहाँ से कोई आवाज आ रही थी? It's okay, there are not many people, you can shout. It's, you don't have to be correct, doesn't matter.
This type of scar.
Okay, scar is not, what is a scar? I mean, subretinal fibrosis is a scar, okay, and this is what you see, you describe, there is pigmentary alterations, okay, there's RP changes, you can say, beetle bronze appearance, or, describe what you see. So again, this is localized to the macula. If you see here, this is localized to the macula, everything else in the periphery is normal. Right, so these are the right and left eye. Now, what additional testing would you think in this child? Okay, so OCT is one, very good. ERG, excellent.
EOG.
Okay, so why are you thinking about EOG? I'm not saying it's incorrect, but why are you thinking about it?
So related to some neurological.
Neurological, so you're thinking EOG for neurological problems, then that's incorrect. Okay, so if you're thinking about EOG, you should be thinking about Best disease. Yeah. So if you said, I thought that this was a scar, the stage of Best disease, then I would have said that's a logical, thinking, but not for neurological condition. Okay. So yes, OCT. This is the OCT. Okay. This is the right eye and the left eye. What we are seeing here is loss of outer retinal laminations. Yeah. But then there are these two round circles. Do you see that? What are these? I think that's a long commitment, isn't it? I mean, if you're saying that, this is accumulation of something, you have to be certain. But what you're seeing here, there are two round circles. I'm not sure if you can see that clearly. So there's one round circle here and then there's one round circle here. So you have to imagine that this is a cross section of a tube-like structure that is going under the retina. Okay? And it's in the, if you look carefully, it's in the outer retina. Okay, so this is outer retinal tubulation, which is present there. This is the other eye. Same thing, until here, you can see that the outer retinal lamination is reasonably intact. Yeah? And then you come here and then there's loss of outer retinal tubulation, just like what we were seeing in the fundus picture. So the peripheral retina appears to be normal. Okay, so right here, normal retinal laminations on the outer side. So this is what it looks like, and again, if you look carefully, not at this now, look here. You're seeing blue areas, which means that there's retinal thinning. Yes, so the retina is atrophic, and this tubulation is actually not a sign of intraretinal cyst, and then you start injecting this patient. Yeah. So we've got the OCT. How about autofluorescence? How many of you do use autofluorescence regularly? Yes. If you're thinking about inherited retinal dystrophies, autofluorescence is one of the really, really useful tests because it tells you things which you cannot see clinically, and you can sometimes use it to monitor disease. And we'll hopefully talk about it later. And that's where you evaluate lipofuscin in the RPE. So this is the autofluorescence of this patient. This is an artifact. The lens where this test was done was broken, but this is the problem. So you see here. That's the area which is abnormal. It's a young child, so it wasn't, very cooperative. And you see that there is a ring here, hyper-autofluorescence ring. Okay? So now the hyper-autofluorescence ring that you see in inherited retinal dystrophies, it's clinically quite significant because in, for example, retinitis pigmentosa patient, that hyperfluorescent ring that you see, it shrinks with time. So as the vision is constricting, the hyper-autofluorescent ring is also shrinking. And it tells you that this area, there's a lot of cell death that is taking place. That's why there's accumulation of lipofuscin more than the surrounding area. This area, there is loss of photoreceptor as well as the RPE. So you do not see lipofuscin, and that's why this is not as bright. Okay. The ring in rod cone dystrophies shrink with time, and the ring in cone rod dystrophy, because it starts from the center, it actually expands. Okay, and it tells you that the disease is actually progressing over time if you repeat the scans after a couple of years. And this test is a non-invasive test, so you can do it in your clinic in 2 minutes, and it gives you, useful. And some authors have looked at the correspondence of this ring with the visual field loss, and it correlates. So as the vision becomes, constricted and tunnel vision, the ring, the autofluorescence ring is becoming shorter. Right. So based on the information we have OCT information, we have clinical pictures, we have some history, and we have autofluorescence. So what is the group of diagnoses that you're thinking about now? Shoot. Okay, so we are discussing sort of inherited retinal dystrophies or masquerades. Yeah? So we're going to discuss a couple of cases which look very similar. So we are thinking about inherited retinal dystrophies, but try and narrow it down now that you have some information. Which kind of dystrophies we are thinking now?
Macular.
Very good. So we are looking at macular dystrophies. Yeah, we don't have more information to narrow it down further. So here are the things, yeah? So we have Stargardt's disease, right? X-linked retinoschisis. How many of you have actually seen a Stargardt's patient?
Yes.
Yeah? So a lot of you have actually seen a Stargardt's, yeah? This could be Stargardt's patient. Yeah, looks very similar to a centralized, dystrophy. One of the things that is absent here is the flex, but flex may or may not be present in every patient, okay? And X-linked retinoschisis, then we have cone dystrophy, central areolar, BEST. I think the thing that you were talking about, EOG, if you said that because I was thinking about BEST, the answer would have been correct, yeah? So pattern dystrophy, the North Carolina macular dystrophy. North Carolina macular dystrophy is just a name, but this dystrophy can take place anywhere. Okay, it's not just North Carolina. And familial dominant Drusen and Sjogren-Larsen and all. Right, so any additional tests now?
Yeah.
Okay, so let's think about ERG. So I'm going to try and keep it very basic for ERG. Okay, so there are 3 types of ERG: full field ERG, pattern ERG, and multifocal ERG. Multifocal ERG will help you to kind of localize the pathology in the retina. So you take a photograph and you do ERG in the local area to assess which part of the macula is working or not working. Okay, we are not going to discuss that. Okay, pattern dystrophy looks only at macular function. It helps to distinguish between optic nerve and macular problem, particularly if VPs are abnormal. Okay, we are not going to discuss that. Okay, we are just going to focus on full field ERG, because full field ERG helps in narrowing down inherited retinal dystrophies. Okay, so it's very important that these tests are standardized. So what we follow ICER standard full field ERG protocol. Okay, in which there are 6 tests. 4 are done under dark adapted conditions. So you dark adapt the patient in a dark room for 20 minutes, and then you do 4 tests, then you light adapt for 10 minutes, and you do 2 tests in the light adaptation. In the dark adaptation, you are basically looking at rod function. Okay, and in the light adaptation, you're looking at cone function, and you can distinguish. And if a child is extremely uncooperative and you're wondering whether this patient has retinitis pigmentosa like problem or night blindness, sometimes you can just do the dark adapted test and that's it. Okay, they may not allow you to proceed to do the full thing. Okay, so these are the ones that we do with the dark adaptation and the remaining. Now, I don't think we have time to go into details of how the origin is, but just try and remember this waveform. Okay, because we are going to come and talk about it. So there is a negative A wave, and normally there is a positive B wave. Negative A wave is smaller than the positive B wave. If the B wave is smaller, then it's called negative ERG. You've heard about it, yeah? Good. So in this particular patient, what you're seeing here is these are the dark adaptive tests, 1, 2. Okay, they are reasonably within the normal limits. Okay, reasonably. And it's a child, so you have to understand the reliability of the test. Okay? This is again, I mean, I wouldn't just go for one, red mark. But here are the tests for the cone. Okay. Now we know that cone is highly dense in the center of the retina, and the tests are coming again within the normal range. So does this test now, which is almost within the normal range for dark adapted and almost within the normal range of light adapted, is this can we conclusively say that this child does not have inherited retinal dystrophy?
No.
Why? So basically, there are a couple of things. One is that the disease may progress with time, so things may become abnormal. And the problem is that when we focus on cone, we think about cone as only present in the center of the eye. But cone is also present in the periphery. So if your cone functions as such are normal, you would get response from the periphery. Even when you're light adapted, you will get response. So in this particular patient, the cones are still working and the rods are still working. Okay? Now this can happen in also conditions like sometimes in Stargardt's disease. Okay, because it's a central area, but the rods and cones alone, they are actually working. Okay. One of the other things that you have to remember that more than 20% of the cells have to be involved to actually show effect on ERG. Okay. So additional information. These are the eyes of that patient. You guys all, you're looking at your patient's eyes day in and day out. What is the abnormality that you see here?
Right esotropia, right inferior oblique overreaction.
Okay, I'm not a squint surgeon, so I didn't notice these things.
Lashes are gone.
Lashes, very good. See, sometimes when you're looking at the tree, you forget about the forest. Okay, so focus on small things. There you go. Look at it. He never had a haircut in his life. Never had a haircut. Okay? So what you're noticing now, and these are some teeth abnormalities. So the eyes cannot see what the mind does not know. So you have to keep thinking about all the possibilities, like artificial neural network in your brain working, trying to narrow down what you're seeing. So blonde sparse hair, these are all the long list of association with the eye. Okay? Just copied it from this book. So much the information that we have so far, that we know that there is some systemic problem. Then we notice the problem in the fundus, in the OCT and the AF, right? So genetic testing, okay? So what do? We send the blood to US. We use it in Vitya lab. They look at 330 genes, and these genes are increasing with time. So when you look at some old tests that were done 5 years ago, they were looking at only 248 genes. So as more genes become available in the panel, those genes are tested. Now this is very important to know, because the panel test, if it comes back negative, it only means that the known genetic mutation for the inherited retinal conditions were looked at, and certain common inherited conditions were looked at. It doesn't mean that there's nothing wrong with the patient genetically, because if you really want to do something, you have to do whole genome sequencing. Okay? So possible outcome, positive, variant of VUS, carrier and negative. We'll discuss that later again. Okay? And in this particular patient, the patient was positive for CDH3 gene test mutation. Okay? And this is associated with congenital hypotrichosis and juvenile macular dystrophy. Okay? Now, this is a very rare problem. Okay? And all these things helped us kind of reach that conclusion. So how common is this? Just throw a number. 1 in 1,000, 10,000? 1 in million. Okay? So you have seen a case which is 1 in million. Take it not as a saying, but really. So far only 100 cases have been reported in the world. Okay? And there 15 cases are from Pakistan, from 2 families, which we think is a mutation within the family. So these are a couple of case reports. And we presented this case at the American Society of Retina Specialists meeting in New York in 2022, because again, this is a very rare case. Right, let's move on to the second case. Can anybody tell me what are the sort of quote-unquote treatable pigmentary retinopathies, your treatable retinitis pigmentosa? Things that you can treat. So you look at a retinitis pigmentosa, you say, okay, halas, no treatment for you, go. Right? But then you should be looking at certain things, because certain things are treatable. And you can help to either prevent visual loss or sometime hopefully reverse visual loss.
Macular edema due to RPE.
Okay, so these are the secondary problems with patients with, but there are certain atypical forms of retinitis pigmentosa which can be amenable to some sort of treatment.
Sir, RPE due to RPE 65.
No, that's again, it's a genetic problem, and it is retinitis pigmentosa, and the only thing you can offer is gene therapy. But there are conditions, Refsum's disease, okay, choroideremia, okay, and more importantly, vitamin A deficiency. So if you look at your patient in the clinic, somebody may have vitamin A problem, and all those patients that you're seeing, there may be one patient that has vitamin A, and you miss that patient, and this patient you can treat. Anyway, so we move on. Keep that thinking in your mind while you're examining inherited retinal dystrophy patient. I know it's very disappointing, and parents want cure, and it's the conversation that takes place is not satisfying. But anyway, so this is a 7-year-old female, poor vision from birth. okay, progressively getting worse. She has nystagmus, not very cooperative. She has hypermetropic refraction and she's obese. Okay, so inherited retinal dystrophy and an obese patient. And another thing that I am throwing in is hypermetropic refraction. Okay, this is the family history. She's right there. Brother is okay. And this is, we are looking at the rod test. I haven't put all the tests. And we're looking at the cone test. So it's flat, so means rod cells are affected. We are looking at cone is flat. So she has gone cone rod dystrophy. She has nystagmus, remember? Yeah. And based on these findings, we are thinking about, you can't see this here, is a condition called Alstrom disease. Okay, Alstrom syndrome. So what we do is send her for genetic testing, and she comes back positive for ALMS1. Okay, and I don't know whether you guys can see this. यहाँ पे तो काफी अच्छा है screen पे. So ALMS1 is associated with Alstrom. What's the big deal? You know, patient has spent money, made the diagnosis. How have you helped the patient? Doctor साहब नजर आएगा? No. But here is the thing. Alstrom children have diabetes. So you need to refer them to endocrinologists. So they develop problems with, you know, early diabetes, and these things are missed. But not just diabetes, they have other problems as well. So you're helping the patient by telling them that your condition is associated with multiple other problems in the body, and what I'm going to do is to refer you further. Okay? And why are these children wearing these goggles, these glasses? They have a particular tint, right?
They are photophobic?
Yes, they are photophobic because of... So people who have cone dysfunction syndrome, particularly people who have achromatopsia and sometimes cone dystrophy, they will find that, you know, orange tinted glasses are actually quite helpful. Okay, so again, once you make that diagnosis that this is actually cone dysfunction, it's always worth giving it a trial in low vision aid with the tinted glasses. The thing is that if you send the patient to the low vision aid LVA assessment, they don't know what to do. They will talk to the patient and then the patient is gone. But if you tell them that I'm suspecting cone dystrophy, please try, you know, or achromatopsia, please try tinted glasses. These glasses I have, and I have patients whose visions have improved quite a lot because, you know, it takes away that photophobic thing. Right. Just because we're short of time, we're going to move on quickly again. So 6-year-old male child. Now this is a very interesting case. It's a long case, but let's follow this. Okay? Gradual, progressive, painless decrease in both eyes past few months. Okay? Unable to maintain eye contact, having difficulty in reading blackboard. Okay? Birth history is not significant. Family history, father has reduced vision. Okay? People have told him you have retinitis pigmentosa, somebody has said something. Okay? यहाँ पे vision a counting finger and 2300, no significant refractive error. Now suddenly, you know, we are looking at refractive error because some of the associations with inherited retinal dystrophies are with refractive errors. Okay, so it's important to know what refractive errors they are. And this is the fundus photo. Okay, so other than slight disc pallor, okay, which may or may not be because of, you know, artifact and the flashlight, what else are we seeing? We see this, you know, pigmentary ring here, okay, that's fine. But overall, the fundus doesn't look too bad. Yeah? So these are the discs here, maybe slightly pale. This is the family tree. Child is affected, father is affected, and you can see mother is related, distantly, sort of, distant cousins. So now this is important, again, family trees in the eye clinic. Okay, so differential diagnosis of severe visual loss and normal looking fundus, okay, because this can also come in the exam. So Leber's congenital amaurosis, Stargardt's disease, cone dystrophy, keratoconus, Leber's hereditary optic neuropathy, and another condition is the unexplained visual loss. You know, I don't expect you to see these patients in the clinic, but these things are out there, so when you see a patient, look out for them. Okay, so on further questioning, there is no history of photosensitivity, no history of nactylopia. So this child is not complaining of night blindness. Okay? Keep that at the back of the mind because father is told by people that he has retinitis pigmentosa. Okay, so these investigations were performed. So this is the autofluorescence image. Okay, it's a child image, so it's not high quality because they don't focus, but you may see something here at the macula, but not a lot. Yeah, there's no clear cut. Unlike the last patient that we saw, there was very clear cut demarcation. But when you see the OCT again, if you carefully focus on the outer laminations where the photoreceptors are, there is disruption. Yeah, throughout. So what's the differential now? Okay, so Stargardt's disease is one. Yeah, cone rod dystrophy, retinitis pigmentosa, sign pigmento, hereditary optic neuropathy, autosomal dominant, but unlikely because the photoreceptors are affected. Okay, any further tests?
ERG.
Okay, ERG, what else?
Genetic testing.
EOG, okay, if you're thinking about BEST.
Genetic testing.
Genetic testing, very good. So the first thing we did was the ERG, and these are the rod response. You can see there is no wave. So, try not to think about all the details, just try and figure out if you can see the normal waveform, but the normal waveform is absent, okay? This is still the rod test, and these are the cone tests, yeah, light adaptive test. Again, if you look carefully, the waveform is absent or, severely attenuated. Same thing here. So, these are the findings. Differential diagnosis based on, now we are doing a test and we are narrowing down what we are seeing. Yeah? So Stargardt's disease, cone rod dystrophy, again still retinitis pigmentosa is there. So I think somebody already mentioned genetic testing. We sent this patient for genetic testing and he was positive for ABCA4. Yeah? So now we associate ABCA4 with Stargardt's disease, right? And when you looked at his eye, there were no flecks. Autofluorescence showed no flecks, okay, which is normal. So this is something to keep in mind. Phenotype, genotype may vary, and we are taught certain way in Kansky and in books that you always look for flecks, but flecks were not there. Okay. So it's the most common inherited retinal dystrophy, in childhood and adulthood. There are types based on ERG. If one cell is affected, both cells are affected, rods and cones. Again, we don't want to go into details, but here is the thing. So these are the 4 genetic mutations that are associated with Stargardt. We know about ABCA4, but ELO, VL4, and PROM1 are also associated with Stargardt. So these are the flecks that we are normally taught that we see in Stargardt, but they're not present in every patient. Okay. And this is the fluorescein angiogram, not of this patient, but another patient. You see dark choroid and you see macular abnormalities. Okay, so what is the difference between Stargardt's disease and fundus flavomaculatus?
Flavomaculatus has good prognosis and it is non-progressive.
Fundus flavomaculatus patients have night blindness, poor doppler vision.
Anyone else? Okay, so basically now that... Sorry, say again?
Macula is spared in flavomaculatus, which sometimes.
Okay, I think the reason I brought this up is because we have to try and be consistent in our terminology. And soon enough, what we will notice that these names will replace by the genetic defect. So we are not going to call them retinitis pigmentosa, we are going to call it RP65 retinal dystrophy. Okay, because the thing with the Stargardt's and the fundus flavomaculatus is that the same disease but different spectrum. So when was the patient diagnosed? If you diagnose in childhood, people call it Stargardt, fundus flavomaculatus if in adulthood, but really there is no difference. Okay, they're the same disease. And the treatment of Stargardt disease, now again, once you've made this diagnosis, it's very important to remember, we describe vitamin A for patients with retinitis pigmentosa. In Stargardt disease, it has exactly the opposite effect. It actually harms the patient. Okay, because this is affecting the RP, and the more vitamin A is accumulated, the more harm it causes. And in animal models, it has been seen that if they are exposed to light, the retina is damaged. So what I tend to do is to tell them that if you go outside, you wear UV protected sunglasses with a special emphasis to prevent progression. And obviously, low vision aid and gene therapy. Right. So this is not the end of the story. Okay, so we all agree that this is Stargardt's? Yep. Oh, now everybody knows. Let's talk about his father. Yeah, we know he has vision problems. So he's a 31-year-old male, decreased vision since age 6 years. Yeah, married to a distant cousin, as we have seen in the family tree. Bilateral nystagmus, no nyctalopia, photophobia is absent. But he's saying that his vision gradually decreased from childhood. Central vision was affected first. Counting finger and hand motion vision. Okay, and he's only 31-year-old. This is his fundus. Keep the child in your mind, now looking at the father. So what do we see? Classic bony spicules? Yeah? Pale fundus and classic bony spicule. I mean, you wouldn't fault anybody if they called it retinitis pigmentosa and they said, I don't need to do any testing. I know this is retinitis pigmentosa and that's it. ठीक है, पैसे जाए होंगे अगर आप टेस्ट कराएंगे. ठीक है? You won't fault them because that's what it looks like. There is a possibility that the father was like his son when he was 7-8 years old. Yeah, he may have had just macular changes without having any peripheral problems. So, what's going on here? So what we do, obviously, we send father for genetic testing. And look, what has he got? So he's positive for ABCA4 as well. So this is not retinitis pigmentosa, it's actually ABCA4 retinopathy. And son has, Stargardt's-like picture, father has, cone rod or rod cone dystrophy-like picture, with retinitis pigmentosa. What, checking the mother?
Yes.
Why would you check the mother?
That's
Yes. So it has to come from the mother. One gene has to come from mother, right? So there are two pathogenic variants. Yeah. So he has got it from mother and father. Okay? And that's the mother. She's a carrier of ABCA4. She's not affected. She's normal. Okay. So now these things are helping patient actually understand their disease. It's helping us to understand the disease. It's helping us to counsel the patient about the next child, or how they wish to plan for their, further life. So here is the thing. So Stargardt's disease, common genetic mutations. So these are the 3 genes. Then we have the ABCA4 related retinal disorders. So we have cone rod dystrophy, we have retinitis pigmentosa, we have Stargardt's disease. So phenotypic and genotypic are overlapping, and you cannot be just certain by looking at a fundus and saying that this is what it is or performing some test. You have to kind of look at other things, and the more genetic testing we will perform, the more surprises we will get, and maybe we will start thinking outside the box. Now again, not trying to get into detail, but these are the things, how many abnormal and severity of the genetic mutation there is. You may get different Stargardt's type, or autosomal recessive cone rod dystrophy, or autosomal recessive retinitis pigmentosa. But again, there is this buzz in the ophthalmology community about ABCA4 gene putting you at extra risk of developing macular degeneration. So mother who is a carrier, she may not get retinitis pigmentosa, may not get Stargardt's disease, may not get other problems, but she's at extra risk of developing macular degeneration. You have to warn her to avoid active or passive smoking, dietary changes, blah blah blah. Okay, but we're not going to get into details. So we've discussed this. So we had a child with normal-looking fundus, abnormal scotopic photopic ERG. Father has pigmented retinopathy. Both child and father were homozygous for ABCA4 mutation. So the final diagnosis for this family is ABCA4 associated retinal dystrophy. Okay? Right, so we have 2 more cases, and I think we have sufficient time. So now that we have thought about all these interesting genetic mutations and everything, so every patient you look at, say, gene test karwa lo, okay? This test actually costs $2,000. Okay? But for Pakistan, it has been subsidized. हम आहन में test करते हैं $250. ठीक है, blood लेके अमेरिका भिजवाते हैं. But still $250 is a lot of money. ठीक है, आजकल के हिसाब से आप convert करें तो ये काफ़ी ठीक-ठाक expensive होता है. So you have to be careful, and you also have to remember. For example, you have identified a patient with maternally inherited diabetes and deafness. So first thing you have to think here कि यहाँ mutation कहाँ पे है. You realize that this is actually a mitochondrial mutation. you send them for this test will come back negative. It will not help you, it's waste of money. You have to send for different tests. You make a diagnosis that this may be an optic neuropathy, okay, some form of inherited optic neuropathy. You send them for this test. This is completely useless. Okay, so first you have to to narrow it down to a clinical diagnosis. Then you send them with all the information you have. Okay, so the genetic testing is something like what the radiologists do. Okay, वो कहते हैं information लेके भेजें. ठीक है, अब आप बोलते हो यार अगर मैं सारी information लेके भेजूँ तो मेरे टेस्ट कराने की क्या जरूरत है. ठीक है, और आप मुझे वैसे ही देख के बताएंगे क्या प्रॉब्लम है. बट जैसे कि हमें आप इन्फॉर्मेशन देंगे तो वी विल लुक एट स्पेसिफिक एरिया एंड इफ देयर आर सम एबनॉर्मलिटीज वी विल ट्राई एंड कोरिलेट विद योर फाइंडिंग्स एंड गिव यू व्हाट वी सस्पेक्ट इज हैपनिंग. Again, a 7-year-old child with nyctalopia, night blindness. She was admitted under pediatric before she saw me for severe weakness and ataxia. Okay? And she was admitted multiple times. Okay? So here are the things, common causes of nyctalopia. Yeah, uncommon causes. This is just to kind of remember. This is what the child looked like. Yeah? She had bilateral ptosis. She had strabismus. This is what her fundus looked like. You can kind of see that, it's slightly featureless here. There's a glistening reflex here of the young fundus of ILM. Maybe slightly attenuated blood vessels. It was just impossible to get good fundus photos on these kids who, don't focus. And it looks slightly myopic as well. This is again, autofluorescence, not very good quality, but maybe some granularity. We don't have the disc in this image because the child wasn't focusing. So working diagnosis for this child is retinitis pigmentosa, right? So that's the first thing you think about, retinitis pigmentosa. But when you think about retinitis pigmentosa, always try and think about atypical retinitis pigmentosa, okay? So these are the association of pigmentary retinopathy, and it's important, for example, in these conditions to make those diagnoses to help parents understand what to expect and refer them to neurologists. So again, there's a long list of what is happening here, but you have to be careful of what you're looking for, yeah? So there's a long list, and we have seen these patients in the clinic, so it's not that these patients don't come to the clinic, yeah? So she was visibly thin, weak 7-year-old child with difficulty walking, clubbing, anemia, 4 arms reveal this. Yeah, these are small lesions on the skin surface. So this is called keratosis pilaris. Slit lamp examination, this is what we see. He's not willing to sit on the slit lamp, but we managed to get this. I give you the picture quality is not very good, but sorry. Yes, very good. So what is it?
Vitamin A deficiency.
Yes. So now you're thinking vitamin A deficiency. Now here is more. So the chronic diarrhea that she was coming to the hospital frequently, she was coming multiple, admission, chronic diarrhea, drip, discharge, admission, chronic diarrhea, drip, discharge, and now we know that she has RP-like changes, and now we also know that she has xerosis, okay, and the first admission was she was 1 year old, okay, and multiple bruises, and she had anemia, vitamin K was given. Second hospital admission was 6-year-old, again for problem, and they were looking at different things. Jejunal biopsy was done, which appeared to be normal and all. Okay. Third hospital admission was at age 6, again UTI, miliary tuberculosis, because she was so thin that tuberculosis was suspected, no confirmed diagnosis. So many other tests, MRI, everything was performed. Okay, and this was our diagnosis. Yeah, we have heard about A-beta lipoproteinemia. Yes? So what do you see? How can you make that diagnosis? You can check vitamin A level, but it's not available everywhere. What else can you do to confirm?
Vitamin K and other.
Yes, you can look at other vitamins, they are abnormal, but they can say a malnourished child. What else?
Blood smears.
Yes, what do you see? No, that's the right answer. Blood smear, cheap test. Yeah, so all the vitamins were abnormal, and you can see vitamin K की वजह से bruising हो रही थी, जो hematoma के साथ बच्ची आई थी, जो infection समझ रहे थे, ataxia from low vitamin A, ठीक है, all the vitamins were low, cholesterol were low. Yes, you see this here? Again, I think picture quality is not very good. So this is a blood smear of our child, the child that is discussed here. And this patient has these spiky cells. Okay? And that gives away the diagnosis. Yeah? And this is patient before and after treatment. You see the skin condition has dramatically improved. All the lesions have disappeared. She had it for such a long time and no diagnosis was made. And that's her before and after. Right, so before we discuss the last case, again coming back to the IRD panel that we do, there are possibilities of a couple of options when the results come back to you. You may have a positive result, okay, but keep in mind that the genes that are testing are increasing over time, okay? And you may have tested for something, but after 5 years, 10 years, there may be other genetic things that are included. And negative, so there could be a negative test that they find nothing. There could be a carrier test that, as we have seen in the mother of this ABCA4 retinopathy case. Potentially positive case. Now, the potentially positive case is a problem where they suspect that there is something, but you haven't provided enough information for them to, because if all of us go for genetic testing, we may have some abnormalities which have no clinical significance. Yeah, to be able to narrow it down, the guys in the genetics, they need some information to narrow it down, that these genes are possibly causing problems. And then this is VUS, okay, variant of uncertain significance. Now here is the problem, because all the genetic mutations in the panel are based from American and European population. So the gene abnormalities are mostly from that population. So there may be some genetic thing that is particular to our population. They don't know it yet. So what they do, they report it as a variant of unknown significance. And let's say that over the years we send them 200 patients which look like Stargardts, and then they come up with the same problem in the genetic, then they will say that this is actually Stargardts. And this particular mutation is common in Pakistani population or common in Saudi and other countries. Okay? And that's why it's very important to provide as much information possible. And sometimes if you have variant of uncertain significance and the genetic mutation is there, you write to them with more information, they will change the result based on the information that you provide. So clinical examination is still very important even in the genetic era. So these are the results of the test that we have performed in AHAN so far. So we have a diagnostic yield of 78%. So almost like 4 in 5 patients have a positive genetic mutation in the samples that we have sent. Last case, again we've been discussing pigmentary retinopathies, inherited retinal dystrophy, genetics, atypical pigmentary retinopathies. We have to keep thinking outside the box and then think very narrow as well. But again, let's not forget the tree for the forest or the forest for the tree. Okay? So this is a 67-year-old male, right? Decreased central vision 3 years ago. Progressive night blindness, both eyes, 5 years ago. Okay? History of presenting illness, there's a cataract, CNVM, no systemic history, counting finger vision, 2200 vision in both eyes, but these are relatively recent onset and he's 67-year-old. That's what the retina looks like. Anybody want to comment? So we are seeing pigmentary changes in the retina, yeah? So again, when you look at pigmentary retinopathy, there's a long list of differential diagnoses that you need to keep in mind. This is the same eye, this is the other eye, and this is UCT hemorrhage because of the CNVM that the patient had. This is the right eye pigmentary retinal dystrophy with attenuated retinal vessels. This is the left eye. Again here, there are peripheral changes, but not as marked as the right eye. And there are intraretinal pigmentation in the second eye as well. And this is what the FFA looks like. Yeah? There's no retinal left really. That's what we are seeing choroidal blood vessels. And this again, you look at the OCT, the outer retina is completely gone. And this is a CNVM in the left eye. Visual field tests were completely useless because the vision was very low. So here is a case of pigmentary retinopathy. Going back to the same differential diagnosis list, what are we looking at? Chronic uveitis, something that you have to think about before telling the patient you will go blind, and this may be present in the family, आपके बच्चों को भी कुछ हो सकता है. That's something that you think about. Autoimmune retinopathy. So we performed ERG test. Okay. Now in this patient, when I presented, the first thing is, in the first slide there was a clue to what is going on. Does anybody remember the age of the patient?
So age 65 and it's been here for 5 years only. So
Yes.
we started.
So this should click. Yeah? So keep this in mind. So this is ERG. This is a normal looking ERG, and this is our patient. So I put a normal ERG so that you can actually compare. Yeah? So this is the dark adapted 0.01 ERG. This is our patient. Yeah, so this is this is 3.0. This is a normal waveform. This is our patient, right and left eyes. This is the dark adapted oscillatory potential, and this is what we are seeing here, normal. And here you can see that there is some A wave, but there is no B wave. So all the other ERGs we have looked at, this ERG is slightly different. Even though there is nothing there, but the weak pulse in the retina is telling that there's something going on. Yeah. So now suddenly you start thinking, hang on a second, if this is negative ERG, what else can be present? And already from the first slide, you have this big question mark about what's going on with this patient. So you look at the cone ERGs, they're also flat, abnormal. Yeah, and cone flicker is also abnormal. And again, this is the maximal stimulus 10.0 ERG. This is a normal patient. So this is the A wave, this is B wave. B wave is always higher. And in our patient, it was negative ERG. And then again, we have long list of negative ERG, what causes. We always memorize them for exam, yeah? But we should also think about these patients in the clinic. So the current working diagnosis of our patient, based on the information we have so far, is autoimmune retinopathy, like cancer-associated retinopathy, melanoma-associated retinopathy. You have heard about MAR and CAR, okay? So we did antibodies for anti-retinal antibodies, and he was, borderline positive to recovered antibody. So now we have another antibody that is positive, recent onset. So this is very important. If somebody has inherited retinal dystrophy, they are going to have, all the kids that we saw were 6-year-old, 7-year-old, right? Now this is a 65, 67-year-old gentleman, and the onset is only very recent. And we have a negative ERG and positive to retinal. Okay? So we are thinking that this may be a cancer-associated retinopathy. Okay? Now, I called the oncologist and I said, listen, I'm really concerned. And she said, well, he recently had a PSA. That's normal. What can we do? I said, we can discuss and do PET scan. That would search the whole body for cancer. So he had a full body PET scan, and there is a hypermetabolic lesion in the prostate. Okay? So the dilemma is, this patient is completely asymptomatic from urogenital point of view. He's come to me. Actually, he flies into Pakistan for his eye treatment from a Gulf country. And these are the PSA is normal. Ophthalmic findings are suggestive of CAR. A patient is completely asymptomatic. PET scan is showing hypermetabolic lesion in the prostate. Yeah? What do you do? Do you tell the patient you have cancer? Just because the eye doctor was saying his funny ERG was showing some abnormality and the test is borderline? What would you recommend the patient?
Send to urologist.
Or just tell them you're fine, just enjoy your life, you'll be blind, but that's okay.
Send to the urologist.
Yes, yeah, so you send them to urologist, but I think not just send them to urologist, you pick up the phone. Because if you send them to urologist, they will just have a look and say, yeah, ये पता नहीं कौन डॉक्टर है, second opinion ले लो, ठीक है? कुछ भी नहीं है तुम्हारे अंदर, ठीक है? हाँ वहाँ परेशान हो जाओ यार, ठीक है? They have 1 or 2 minute time in their clinic. You call them up and you tell them that, listen, I am suspecting cancer-associated retinopathy. I think this guy has a cancer. Can you please look at it? Okay. Then when the patient comes in, they listen to the patient and listen to the story. Same thing happened with the oncologist. She was very reluctant to do a PET scan on a patient who is completely asymptomatic, and more importantly with a normal PSA level. Yeah. So this is the normal histopathology of a prostate gland. Yeah. This is not a histopathologist. Okay, these are basal layers, luminal epithelium, and this is our patient. So loss of basal cell layers fused and ill-informed gland. This is normal. and our patient, this was completely absent. So this is, he had multiple side biopsies of prostate, which showed prostate adenocarcinoma, picked up really early, asymptomatic. Okay, so the final diagnosis in our patient is cancer-associated retinopathy as initial presentation of biopsy-proving prostate cancer. It started with pigmentary retinopathy. Yeah? Right, so I'm not going to go into the details of what is scar or not, but really take-home message, number one, inherited retinal dystrophies are likely to have some form of treatment. At least some of the inherited retinal dystrophies will have some treatment in our lifetime. So we have to start thinking about those patients and how to manage them, where to refer them, what kind of things are more appropriate for each and every patient. And diagnosis is the first step, and the more patients are becoming educated, they are not happy with the diagnosis of night blindness. They want to know more. Sometimes they want to know more for their own benefit, that to see whether they will be living long enough to see, or they will have other problems and offspring and family planning and all. Okay? The genetics of IRD are becoming cheaper. So when I came to Pakistan in 2010, the same company, the same test was for $2,000. Okay? And as the time progressed, over time it's becoming cheaper and cheaper, and there's a possibility that in next 10 years we will get a COVID test. You do a buccal swab, you put it on the thing, and there will be a chip, you connect it with your Bluetooth, and it will tell you your diagnosis. All these things are happening, and it's possible. But then they will come to us with a diagnosis. Say, Dr. Saab, ye dekhiye, ye print out aaya, ye wala wo batane kya karunga. So we have to be aware. And we should be offering genetic testing to our patients. And one very important point, that negative test only mean that the genetic mutations that were looked for were absent. Okay, it doesn't mean that everything is absolutely normal, but that's the more cost-effective way of finding out the things. Yeah. These are my acknowledgements. Thank you very much. I think we have 3 minutes left, so if you have any questions, I'm happy to. Again, I am very careful about vitamins. I'm very careful about vitamins. Even in retinitis pigmentosa, the role is not very well established. So I actually personally don't prescribe any multivitamins. I just tell them that avoid bright light, try using sunglasses when they're outside, smoking, whatever general, but I don't give them any vitamins. Star even in retinitis pigmentosa, the role is very controversial, to say the least. Because the doses that are required in just 1 or 2 trials from the US are very, very high. They can cause liver toxicity. So what we do, we don't give them the high dose multivitamin. We give them some moderate dose, which are hard to find. And then if they have problems, who's going to look after them? And again, the evidence is not very conclusive. And that, I just show me the evidence. That's what I would say. Show me the evidence. I want to see randomized controlled trials which are showing not just extra pigment, because some of the companies will come to you and say, look at the pigmentary concentration at the macula, it is improved with lutein or these, and I want to see that my patient will get benefit by taking this medicine. Because my problem is that when the patient comes to me, I prescribe him or her a medicine, she will take that multivitamin 2,000, 3,000 rupees box for the rest of their life, may not eat healthy diet, will not come to the doctor because they can't afford the fee of the doctor, but they will take the medicine because they will think they will go blind. And I have just given them something with completely, thin evidence and probably no evidence. And one of the important things, vitamin lene se kya hota hai yaar? Kya hoga? Vitamin hi to hai. Let's go back and think about macular degeneration. From ARIDS 1, why do we have ARIDS 2? Why didn't they not continue ARIDS 1? Because ARIDS 1 formula for macular degeneration was causing cancer. So vitamins were causing cancer, they're not harmless. Okay, so they were causing cancer in men with smoking tendency, blah, blah, blah. That's why they changed the formula. So let's not take vitamins lightly. If there is evidence, randomized control trial, more than happy to prescribe. Okay? I would like to see that evidence. I haven't seen it yet, so I don't prescribe those multivitamins.
I'm a dermatologist actually by profession. So we do a lot of testing, genetic testing, but we have to send it to either to Germany or to the US where I train. Where do you get did the testing and how expensive is this?
Okay, so where are you working?
I'm in Lahore.
Lahore. So I think this is done by Ahan. I work at Ahan. So we have this genetic facility. So there's Dr. Salman Kirmani and Dr. Fiza. So we refer to them. So they have come up with
In-house?
no. So this is Invita Lab in USA. So they have come up with a deal to kind of do this.
How expensive is it?
$250. So original cost, if you get it done, if you get it done in US, it's quite expensive.
Yeah, we have to pay about $12.50 or something.
No, I would recommend, if you want, I can give you number to connect with the doctor and refer
I know
person.
Dr. Kirmani, but he's the one.
Yes, Salman Kirmani. Right, thank you very much, everybody.
थैंक यू रहमान बिस्मिल्लाहिर्रहमानिर्रहीम। एक सिद्दीकी गया तो दूसरे सिद्दीकी ने संभाल लिया और आप लोगों ने उठना नहीं क्योंकि ऑक्लोप्लास्टिक और एस्थेटिक का सेशन शुरू होने लगा है। दिस इज़ एन एरिया वेयर वी हैव गॉट थिन हैंड्स ऑन एक्सपीरियंस बट वी हैव गॉट लॉट ऑफ पेशेंट्स हु आर गोइंग टू एल्सवेयर। सो आई वुड रिक्वेस्ट वी हैव गॉट ए वेरी लेजेंडरी डर्मेटोलॉजिस्ट फ्रॉम लाहौर, Professor Azim Jahangir, kindly take the chair for this session. Is Yasir here? Yasir nahi hai. Meanwhile, we can request Dr. Aisha from Karachi because lot of aesthetic is going on in Karachi. Achha sir? Yeah, Yasir. Or Ashar is going to moderate the session. Thank you very much, sir. Thank you. Bismillahirrahmanirrahim. As I already alluded that this is an area where we, the ophthalmologists in general, and oculoplastic association and oculoplastic surgeons should pay more attention because there is a large number of patients, those who are determined to have cosmesis for beautification, but not only those, but there are also those who have got really the practical and functional problems, especially the younger age people who are going to go for marriage or for jobs or for interviews. They take it really serious. We'll start with the upper lid and blepharoplasty. And I'm grateful to my fellow Dr. Sadia. She's here. She has been helping a lot in this oculoplastic program, and I wish that we have more and more fellows as we discussed earlier in the oculoplastic meeting. So the aim is improving the appearance of eye. But perhaps Professor Jahangir would also agree with me that these people have got something in their mind. They have got a body image and we need to match with it. So we need to be very careful and clear what image they are looking for. These are different factors which promote the lid laxity, upper lid laxity and excessive skin for these patients. Especially these are certain factors which we can avoid, like smoking. And also Azim would also elaborate on that. People start mopping their eye, clean वो बड़ी जितना जोर से करते हैं, उससे there are the adhesions of the skin with the deeper tissue, these adhesions are broken और उससे भी वो हो जाता है. We need to tell them how to clean the eye. वो आपने demonstrate करके बताना है. So detailed history and exclude any underlying comorbidities and also exclude any underlying ocular disorder. The last one, the visual field testing I have kept here. It is very important because most of the time the insurance agencies, they don't pay for this service. But if you can prove that the dermatoclasis is overhanging in the visual field area and it is creating a functional problem, then they are more likely to pay for it. तो ये एक ज़रा क्यों अजीम भाई ये tricks और ये parts हैं ऐसे which we need to do because the healthcare cost recently has shooted up a lot. Okay, now photographs are very important, and Sadia is here and she knows that I really get very angry if somebody goes for on the operating table, especially if goes under general anesthesia and the pre-operative photograph has not been taken. Because whatever you do, sometimes the patients are not very grateful and they say, मैं तो पहले ही बड़ा अच्छा था. So you really need to have a proof. और मुझे याद है कि जब यूके में मेरी ट्रेनिंग हुई, they had this SOP that they'll have a photograph print out in their paper, in the notes. डिजिटल नहीं वो मानते थे, वो कहते थे आप प्रिंट लगा लें, क्योंकि डिजिटल पे भी बाद में लोग जो लिटिगेशन में जाते हैं वो कहते हैं ये तो इन्होंने खुद डिजिटली चेंज कर दिया हो. एंड देयर आर वेज टू डिजिटली चेंज थिंग्स. और ये अच्छा इसने सादिया ने पॉइंट बताया कि यू आस्क देम टू गिव ए 10-year older photograph because perhaps that's the image they are pursuing. वो आके पेशेंट ये कहते हैं मेरी एडी वड्डी वड्डी अख सी ज़ेबा वर्गी, हूँ देखो की हो गया मैंने. So that is the natural aging process, but the people sometimes fail to acknowledge that. So we should have realistic hopes and exclude all those potentially poor outcome people. उनको मेरा ख्याल है अजीम के पास हम रेफर कर दें. He has got great counseling team. We must learn. He is going to tell us about that. So we need Farzad Pakdil presented, and I think also on the other day. And it is very important that you identify that the male eyebrow and female eyebrow are different. वो इसके बारे में तो उर्दू शायरी भी बहुत है, क्यों नहीं तैयब सर? इसी के बारे में तो तीर आधी शायरी तो आँखों के बारे में है. तो वो हमारे उस्ताद कहा करते थे तेरी आँखों के सिवा दुनिया में रखा क्या है. So we need to identify that, और इसके लिए पूरे वो नोमोग्राम्स हैं, आपने कहाँ पे इस क्यूपिड वो को पीक करना है. But for the male it is more horizontal. These are all the आप जो फेलोज हैं इसकी तस्वीर उतार लें, ये कुछ मेजरमेंट्स हैं, इनका आपने ख्याल रखना है. These are the indications. Excessive skin. Sometimes actually the blepharochalasis actually comes and goes, but sometimes it is so bad and that you may need to do upper lip blepharoplasty for it. And these are the contraindications if you have a underlying disorder. Please do not forget that the gravity is playing a very important role in the lid position and the baggy eyelids. So whenever you are marking, ask the patient to sit up. Then you mark. ये आप आ सकते हैं इधर थोड़ा सा डेमोस्ट्रेट आप इधर आ जाएंगे, इधर निशान कुछ लगाना नहीं इससे मैंने बताया इधर खड़े. So we ask the patient to sit up or stand, and then we mark the incision. First the skin crease incision. So first we mark the skin crease incision, and then we mark a little dot, and then we make sure, holding in the forceps, the amount of skin we are going to remove. And then we ask the patient to close the eye. And we make sure that the patient is able to close the eye. So that means you're not removing too much of the skin. Otherwise they will develop lag disturbance. Thank you very much. So you mark, and in the outer part you go a little bit higher, but stay away from the going too much on the orbit. So you just peek it a little bit, and this is how you can pinch the skin. Just gently tell the patient, this is before you give local anesthesia. Tell the patient that you'll feel little pinch, and these procedures are best done under local anesthetic, because then you can alter the position and produce more predictable results. And also I think one point I would like to highlight, that leave at least 10 millimeter of the pretarsal skin. And similarly, perhaps from eyebrow lower edge to the upper incision part, leave 10 millimeter there as well. 12. 10 millimeter there. So that, and again as I said, ensure that the lid closure is complete. So this is the part of the orbital fat and skin. You can remove the fat as well, but do not remove too much of the fat as well. And also a little bit of cautery, enough to control the bleeding, as well as that also would squeeze the herniating fat as well. So we don't remove too much of the fat. And this is one patient before and after surgery. And make sure that post-operatively they avoid makeup, eye makeup, and use a lot of lubricants. Initial ice packing and head elevation is very helpful. Maybe for 1 week, namaz, sajda with ishara. But I remember on one patient I was saying कि जी आपने नमाज इशारे से पढ़नी है, तो उसका साथ वाला जो केयर था वो हंसने लगा. मैंने कहा क्या हो गया जी? क्या मैं अल्लाह करे पढ़ ले ये नमाज. तो हर हाल हमारा फर्ज है कि हमने बताना है. So complications can happen. Immediate post-op, hematoma, intraoperative, even they can be retrobulbar hemorrhage if you go too deep. 0.04% blindness is a bit of overkill, I believe, but this has been reported. So especially, I don't know, in UK there are certain, in the blepharoplasty is going on in the optometry offices. So there are also visiting surgeons coming from European Union, performing surgery and going home on that evening. So that kind of problems. This is me and Sadia together, because my other fellow, she has gone for an exam in UK, and the third one is on maternity leave. We have got 3 orbital oculoplastic fellow, and Professor Asad is also here, he is the supervisor as well. Thank you very much for training and teaching the oculoplastic.
Thank you very much. Next speaker I call Dr. Zafar Islam. He is not here.
Professor Zafar Islam is not well. मेरी बात हुई थी कल उनसे, तो उन्होंने मुझे खांस के भी सुनाया, ये साबित हो जाए. तो मेरा ख्याल है वो कह रहे थे बुखार भी है. वैसे हम उनके लिए दुआ कर रहे हैं सारे कि अल्लाह ताला ने सेहत दे. आप ये हमारी दुआ की सबूत पहुंचा दीजिए. और because he is a very eloquent speaker, and it's always pleasure to watch him, teaching us. Thank you.
Then I request Dr. Azim.
Can I please request Dr. Yasser if you would like to come and share with
Assalamualaikum. I'm Professor Azim. We will be actually going over two important subjects as far as the oculoplastics is concerned. Fortunately or unfortunately, since I've done in dermatology, internal medicine, then cosmetic surgery, and then aesthetics from the US, I have a little bit different perspective when people say that it's only in their brain, but sometimes they are also right also about the problem. We'll just delve into, I have 10 minutes, sir? 10 minutes? 10 minutes. All right. So we'll quickly go into the problem, where the problem starts. The problem starts as we age, everything goes south. So everything goes down and medially. So that's called the aging vector. And why does it do that? Because our bone, our muscle, our subcutaneous tissue, and the skin, everything starts to lose its volume. So if you see an older patient, let's just go through that. So muscle, Alright, so muscle tissue laxity, but sometimes the muscle and the fat starts to, thank you. So, muscle and the subcutaneous tissue and the bone all together, when they recede, you'll have a hollowness. So how to fill that hollowness? We cannot put in the muscle again, we cannot put in the bone again. The only thing we can put in easily is the subcutaneous tissue. So there are different kinds of subcutaneous tissue. The fat is the most common one. The problem with the fat is that you have to take the fat out. We do it routinely because we do cosmetic surgeries routinely. So for us to do the fat removal is a little bit easier. But for ophthalmologists, it could be a little bit challenging to do the fat harvesting first and then injection later. So the easiest thing for you will be some kind of filling. So we'll go through the filling process. Alright, so you can see there are very, very interesting studies done in the literature that people have done MRIs, people have done confocal microscopy, people have done linear microscopy that shows that the hollowness increases. So the whole diameter of your orbit actually increases. Eventually, you'll see this. So what is happening here? If we go through this process from here to here, how did she get there? There are three processes that you should remember, and two of them are very, very close to your hearts. You just have not paid attention to that. This laxity of the skin is not just the laxity. This is the hypertrophy of your frontalis muscle, orbicularis oculi muscle. These are the two muscles which get hypertrophied. जिस तरह आपकी bodybuilding होगी, right? So if you have bodybuilding, you don't need any blepharoplasty for that. You don't need any filler for that. You don't need any. All you need is the Botox. And Botox, as you know, was not invented but very much refined by ophthalmologists. So one of our colleagues, when I was doing my fellowship in the US, she was at the top of it, and she actually taught her dermatologist husband the Botox because she was actually injecting it in your orbital muscles so that the bring up and ठीक हो जाए. And they ended up having wrinkle removal, and that's how the wrinkle removal was started with the Botox, because they were injecting it intraorbitally for those muscles to straighten your eyeball, and they ended up removing the wrinkle. All right, so you should know your history. Here, the subcutaneous fat layer is depleted, so we need to replace that. We need to do Botox over here, and we need to replace a lot of, you see, this fullness is basically has to be filled by some kind of tissue. This is the subcutaneous fat. I mean, I thought that anatomy is done with. I mean, we don't need any further anatomy, but you'll see that anatomists are actually coming up. In the last 10 years, we have started to know that there are fatty compartments which are very superficial fat. This is not a deep fat. So the superficial fat compartments are actually delineated by septa, and if you cross the septa, you will be doing something wrong, and we'll talk about it. One of the other things that happens is that all the subcutaneous tissue is gone and it is replaced with the hypertrophic muscle that you have been using for years. So let's jump into because we have to cover two topics, we have very little time. So let's just jump straight into the topic. So there are three kinds of fillers mainly. There is no epidermal filler because epidermis is only 0.5 to 1 millimeter. The rest of it is dermis, about 4 to 6 millimeter is the dermis. And then the subcutaneous tissue. It depends which area of the body we are talking about. I'm talking about around the periorbital area. So there are superficial fillers, mid-dermal fillers, and deep fillers. So just to give you a rough idea, because this is the most important thing that you have to learn. So no epidermal filler, mostly dermal fillers, and few subcutaneous fillers or the fat fillers. Alright, if you go into the history, you'll know that it is nothing new. We are not doing something new. We have not actually invented anything. We are just trying to finesse the pre-existing knowledge. That from 1893 onward, we have been experimenting with different kinds of fillers, and fat is the safest one. But the problem is there. We will talk about it. What makes an ideal filler? If it's not fat, what is the ideal filler like? So these are the characteristics. So non-allergenic, it should not cause any allergy. FDA approved, non-carcinogenic, non-teratogenic, no migration, and we'll talk about it because you don't want to put it on the under eye and then it travels down to your throat. You don't want to do that, right? No overt cutaneous change, it should be undetectable. Reproducible results, durable, minimal sequela, stable, which is inert and affordable. Administration-wise, there are few criteria, but the thing is that it has to be very predictable insertion to keep it very, very simple. The most important filler and the most inert material you can get is something which your body makes. So your body makes in the dermis, one is collagen. Problem is that the collagen cannot be produced artificially. We used to have collagen fillers about 20 years ago, but we have to do allergy testing on them. From then onward, we don't have to have the collagen fillers because we have a better molecule which is not non-allergenic. So it is not, and it can be reproduced in the lab. So hyaluronic acid is the most common filler that we use these days, and for the last 20 years, I think I've used it almost with zero complication as far as the allergies are concerned. So now, since it's produced in the lab, it does not carry the problem of any viron or viruses in that. So it's pretty much stable. Half-life of the natural hyaluronic acid is less than 24 hours in the skin. So natural hyaluronic acid will be produced and will be reabsorbed into your body in 24 hours. So we don't want to do that. We want to make it stable. So we cross-link the molecule. Cross-linking keeps it stable for the next 6 months to a year once it's in your body. Now, there are different kinds of fillers within that category, and you'll have to just read about it. It's made from hyaluronic acid with the bonding of between the strands of the hyaluronic acid to keep it stable. So more bonding means more stability. But remember one thing: it will give it an unnatural phenomena also because your own body is not cross-linked. Your own body's hyaluronic acid is not cross-linked. So if you do too much cross-linking, body may start recognizing it as a foreign body and may react to it. So you have to understand that more cross-linking means more longevity, but as allergenicity also. All right. I think let's just cross that because we don't have that much time. Now, the second thing you should know that each company makes different fillers. Some are more viscous, more thicker, which means that the per ml of the filler, you'll have more hyaluronic acid and more cross-linking and more durability and more thickness and more volume. But the problem is that you'll have to know where to use which one. So if you have less cover or thinner skin, you will use some thinner fluid. If you have a lot of skin over the area, you can use a lot of thicker material. So you'll have to just learn that which particular company you want to use, and you have to just study their individual filler to make sure that this is of your interest. This is one of the routine fillers that we use, for example. So you see that this is the filler, and it is a white, like transparent filler. It comes with different 27 gauge, 30 gauge, 32 gauge needles. 32 gauge is not available in Pakistan. You will get it from the US. You can do the same thing. As you can see that from this cartoon, that the epidermis is very, very thin. You cannot go over here. The bigger the molecule, deeper you'll have to place. Alright, so this is just a general rule. Here the same thing. That bigger the molecule, you'll have to use it. This is the thin one, this is the big one. So the drop is also bigger and thinner depending on the viscosity of the filler. Alright, so this is the little bit of a, I didn't have that much time to make more videos. We have a lot of videos, but that would be too long. I'm using a cannula rather than a needle, because cannulas are blunt on the, because we do a lot, anybody who does a lot of liposuction should know that the cannulas are atraumatic, so they are round at the edge rather than the needle. It shouldn't, or it doesn't really poke through the sensitive tissue, and it's much more safer. So you use cannula rather than the needle to make it more safer. So this is a typical result. As you can see, either we could have done the lower blepharoplasty. I used to do a lot of lower blephs in the US, but then we stopped doing it almost because it will create a hollowness in the eye, right? And we thought that let's just keep the fat over there and just inject it underneath the nasojugal fold. So that actually brings a better result rather than the blepharoplasty. If you have to do that, what I would recommend is that tighten the skin rather than doing the blepharoplasty, which can cause the ectropion. You can do fractional laser resurfacing that will actually create 250 micron spots, and that will actually contract the skin, and then the need of the filler will be less. So the use of filler, because it's more expensive, will be less if you can contract the skin, so it will go back a little bit, and this groove can be filled with the filler. So let's just go through a couple of other slides. This is another slide. You can see that this lady, either we could have done the lower bleph or done the filler. The beauty of the filler is that it can be done in outpatient in 10-15 minutes, and then you are done with, right? Same thing over here, same thing over here. That this filling has to be done in the nasojugal fold, and sometimes you have to do it all around it. Same thing over here, same thing over here. That this patient could be treated with multiple ways, but the easiest thing would be to do just the filler over here, and probably a couple of sessions of lasers if required. You can actually do it without that most of the time. Same thing over here, same thing over here. Alright, fillers can be used anywhere. For example, in this patient, we used it in the nasolabial fold and marionette line, and rather than doing the facelift, you can get away with the filler. So fillers are very, very handy. You can do very, very quick. You can do it in the lips, you can do it in the marionette fold, you can do it in the nasolabial fold. So you can make the lips in different shapes, sizes, and forms. You can do it on the nose also. So rather than doing the rhinoplasty for small things, this patient had crooked nose both, right? So what you do is that put a little bit filler over here to actually give it a boost, and a little bit filler over here to make it straight. Same thing over here. You can do it on the breast also. You can do rather than giving them breast implant, which is quite unnatural because it contains silicone, and silicone, as you know, that it has its own complications. It's much easier to do the filler. You can actually, the only thing that you should be worried about in filler, the most important thing is after the infection and everything, I'm sure that you're very, very cautious about it, is the occlusion of the blood vessel. So you don't want to do intra-articular ones. So you should be very, very familiar, and I'm sure you are, but you should be a little bit more familiar with your vasculature than a routine ophthalmologist who does not deal with the rest of the face. So if you, God forbid, inject into the vessel, the whole area will start becoming purple first, and then it will necrose. So that's very, very dangerous. But the most dangerous part, and this is the less dangerous part, because these fillers are like water-like, right? They are transparent. They can show underneath the skin, and it will give you a little bit of a little bit of a grayish hue, all right? So you should be familiar with that, that can be a problem. So make sure that your skin is thick enough to hide the filler underneath it. Now, this is another case. If this happens, God forbid, and then the nodules can form, like this one. Nodule again on the outskirt of the temple. Nodule on the lip, nodule here. Now, there are adverse effects you should know, but the worst one that you need to be familiar and you need to how to fix it, you should know that, and that is basically how to declog the occluded blood vessel. All right? How do you do that? So I just wanted to touch a few slides on this one because this is the most feared complication. It's a real complication because I see this happen once in a blue moon, but you should know. So why are we treating blindness from fillers? So this is not a story. This is the real one. If you look in the literature, in dermatologic surgery literature from 2000 onward, you'll see a lot of blindness cases. Not a lot, it means that thousands and thousands, but more than you would expect. And one of the reasons is that the people forget about the anatomy and they end up injecting inside the blood vessel. So avoid the blood vessel as much as you can. You don't want to poke into the blood vessel. And what happens if you do that? God forbid. This is what the problem is. We don't worry only about the skin, we worry about the blindness. And the theory is that the filler goes with the retrograde flow. The filler goes into the ophthalmic artery, from the supratrochlear all the way into the ophthalmic artery, and then central retinal artery and occludes it, and then people can get blindness. So you need to know how to prevent that and how to fix it, because not only your colleague may do that, many dermatologists or the plastic surgeon may end up doing it. So what to do? So these are the cases, and these are the real cases. From Korea, there were about in dermatologic surgery in 2015, there was a study, and most of the cases are coming from Korea. I happened to be the reviewer of one of the papers, and what was the interesting thing was that everybody ignored that most of these Korean cases, because people call them chapte, right? They are flat-faced. People think that they are flat-faced. So in order to improve the projection, they were using a lot of filler, a lot of material to project that anteriorly. Once you inject so much filler, you end up having some of the problems. One of the problems was that since the fillers are very expensive, they were using a lot of fat. Problem with the fat is that once the fat clogs your artery, you cannot declog it. You cannot go and do angioplasty, right? So you have to know that if you are going to use a lot of material, do not use fat. The problem is the fat is the cheapest one, so you can take as much fat. So if you end up taking that, always use the bigger cannula, which cannot enter into an artery. So use like I would say 1.5 onwards, 1.5 millimeter onwards in diameter, so that you cannot actually go into any artery. All right. Second thing that you should know is that God forbid if it happens, what to do. This is what. Let me just go straight into the last few slides because I think how many minutes more? Sorry, because it was a hyaluronidase. So we'll actually wrap up in the next 1 minute or so. Hyaluronidase you should be very, very familiar with. कि hyaluronidase की कितनी किस्में हैं? Try to use recombinant one. Do not use the bovine or any other one because you'll have to do the testing. So hyaluronidase comes in different varieties. I'll just go through that. And you should know the dose of that how much hyaluronidase has to put. And at least, if you are not interested in any of this, at least learn how to dissolve the hyaluronic acid injection if it is God forbid going to cause blindness by anybody. How to do the retrobulbar one. Retrobulbar injection of hyaluronidase. I'm sure that you know that already, but if you don't, at least learn that, because you will be seeing a lot of complications because a lot of non-doctors, not the non-doctors, but doctors but without any training are doing it these days, and you'll see, God forbid, more complications. So you should know how to deal with it. All right. So these are different kind of hyaluronidase. This is the one that is available in Pakistan that we use if we ever get referred any patient who has a trouble. So you should know that. last 30 seconds we should just spend on, I knew that 10 minutes are too short for two topics, but a fat transfer, you can actually do the fat, take the fat out by liposuction and inject that. This is how we inject the fat. The same thing, you can, same areas, same thing but cheaper or without any cost. Alright? Platelet-rich plasma, you know that we only take the white blood cells out and the red blood cells out, and we only inject the platelets, but you actually activate them so they spit out all the growth factors. So those growth factors are good for many reasons. And one of the reasons, so why are they so important? Because they have a lot of PDGF, FGF, EGF, IGF, TGF beta and VEGF. So and KGF also, but KGF is less important, carotenoid growth factors. So these growth factors play a pivotal role in promoting two things. Number one, small areas of fine lines can be corrected, but I like for depigmentation or when people have the darker circle, this somehow it suppresses the melanocyte stimulating hormone, MSH. It's stimulating, rather than stimulating, it depresses MSH and people get a lot of benefit with the dark eye circle, in my humble opinion. That's what I use it for. Or if the lines are very, very fine. So you know how to use it. If you don't, just learn it. It's not very difficult. And once you use it, you can use it in different, and it's pretty simple. Always stay subcutaneous. Don't go deep. Don't get into the eye. Why? Because it may clot. So you don't want to put a clot into intravenously, right? Just like the filler. But the problem here is that it will be a clot, and you will not be able to dissolve it easily. All right. So that's what it is. And here, what you can see. So that's pretty much the last slide. And this is what you can actually see and improve in these patients. So last few slides are just my where I trained, and there is no other way to thank them but to just call them. Fortunately, we got from 2018 onward, we are the American Society for Dermatological Surgery Fellowship in one of the sites in the world, which have like 4 sites, and we are one of them. If you ever want to visit or learn or send your fellow as a rotation, you are most welcome. Thank you so very much.
What's your address?
Defenseman.
Thank you, Dr. Deep, for deep talk on deep fillers. I invite Dr. Yasser for low lead blepharoplasty.
Okay, well, thank you, everybody. Assalamu alaikum. It's nice to be here. I'm going to talk about the lower lid blepharoplasty. What can I say about the lower lid blepharoplasty? You know, I think that the upper lid blepharoplasty is a skill set that many of us can easily acquire. Even though, I mean, you need some fine tuning, but I think when it comes to lower lid blepharoplasty, it's a very specialized area, and I think that you really got to know what you're doing to really dwell into it. I mean, even you know, after 20 years of being in a very busy oculoplastic practice, you know, I don't think there's one single oculoplastic surgeon that I've ever met in 20 years that has not said that, you know, they just, you know, the lower lid blepharoplasty takes some time to really get it right, and they still don't have it right, and we're still learning constantly. And I'm learning as well, and I've changed, you know, how I've done my lower lid blepharoplasty a lot. And I think I've come down to a technique that I really like, which is which I'll talk about. The lower lid blepharoplasty is a fantastic procedure. But of course, as time has gone on, we've changed our perspective. For example, you know, in the old days, we'd take too much fat out, give a skeletonized look to the eyelid. Then we say, you know, then we sort of take just a little bit of fat out. Then we do repositioning, whatever. So I think a trend is towards not taking a lot of fat out or no fat at all and repositioning fat. And you know, definitely fillers have come a long way, and doing filler augmentation in the right patient. Remember, it's I always say, you know, in real estate, you know, back home, we say location, location, location. Here it's patient, patient, patient. So you have to pick the right patient. And fillers are fantastic. So not every patient needs surgery, and fillers have come a long ways in augmenting or replacing a lower lid blepharoplasty in some patients. And again, you know, as people will say, it's all about the eyes, right? I mean, and COVID with our masks has convinced us that, because, you know, when you look at a person's face, what's the first thing you look at? It's their eyes, then their mouth, but it's their eyes, really, right? So if your eyes are good, if you've rejuvenated the upper and the lower eyelids, you don't need to rejuvenate the face per se. That does the bulk of the thing and giving you, not making it look more beautiful, just giving you more confidence. It's all about feeling confident, right? It's not about being more beautiful or less beautiful. It's just confidence. And so we all go through that. Now, I will say that, you know, patients have given me permission to use their pictures, so I'll use some pictures. So please avoid taking photographs of the patients. You can photograph my slides if you like, but patients, please avoid. And so, what do we consider as young and attractive, right? So, I mean, you can see, beauty is in the eye of the beholder, but there are some key characteristics that we consider attractive for both men and women, okay? And this is not a trend. I mean, this has been going on for a long time, and I think now as time goes on, we're a lot more conscious. This is an actress, Elizabeth Hurley. This is her at age 39, and this is her at age 56. Right? So she's clearly aged very well, and she has had some enhancement procedures. It's not by accident that she looks so good after more than, after 15 years. So, when it comes to the lower eyelid aging, there's basically three areas that we look at: volumes, laxity of the lid, and laxity of the eyelid skin. So when it comes to volume, there's, in the infraorbital and orbital malar grooves, there's a depression. There's also a increased orbital prolapse. You can see here. This is a painting of an elderly lady. When it comes to laxicity of the lid, there's inferior sclerotial, there's horizontal shortening of the fissure, there's rounding of the lateral corner, and she exhibits all those three things. Then finally, there's looking at the laxicity of the eyelid skin, and not only do we lose the collagen attachments that keep our skin tight, but the skin just kind of sags. We don't grow more skin, we just lose that collagen that supports the skin. This just gives you, hold on, next, okay. Is it switching? No, there we go. This just gives you a nice picture of what happens. You can see all the yellow, which is fat, is decreasing as we age, and the eye is getting more rounder. So it just gives you an idea of that. Now, this is a very old painting from the 1800s by a very famous French artist called Charles Lenoir. Now, you can see this is in the 1800s, but what we consider the young eyelid or attractive has not changed for hundreds of years, right? So basically, it's a smooth eyelid with a smooth eyelid cheek transition, right? Where the T-trough deformity is. A short eyelid vertically, long horizontal fissure, acute lateral angle, sort of an almond-shaped eye, and kind of light skin, no dark circles. Those are all things that are still attractive today, and still is the goal of many people when you're looking at eyelid rejuvenation. So, facial beauty is linked to the eyelid fissure, and studies have demonstrated that narrower eye fissures are more attractive, right? So as the eye fissure widens, it becomes less attractive, and that's something to keep in mind when planning your reconstruction. The other thing to note is that across all cultures, the common things that people want in the lower eyelid and shape is actually very similar. Yes, there's some racial differences. For example, the Asian eyelid, but we're very, very similar in the shape of the eyelid. So, what have we learned from history? We don't learn from history very well, right? And we keep on making the same mistakes. But what we learned from mistakes of the past is the transconjunctival lipectomy causes a lot of periorbital skeletonization, okay? And it has in the past. It became very, very fashionable, but it led to a lot of skeletons, sunken-in eyes, which actually ages you, right? Then there is also the transcutaneous skin and muscle excision, but that has a high risk of eyelid malposition, eyelid retraction, and just this is actually very well-known American singer who died actually a few years ago, Kenny Rogers. This is always given because he just had a really bad blepharoplasty. And so you don't want this, you want to avoid that. And I think the first two techniques of transcons, too much fat or too much skin, is not good. Now, what's the basis for lower lid bags, okay? So what's the basis for an appearance like this, with an aged, sunken, depressed appearance? Well, 52% of this is caused by a cheek descent and hollow tear troughs. About 51% is prolapse of orbital fat. Skin elasticity and sun damage plays a big role. Even if you have pigmented skin, it can still get sun damage. So sunscreen is recommended for everybody as an anti-aging medication or secret. Eyelid increased fluidity, and plus some patients get cheek festoons, right? So the goal of today's lower lid blepharoplasty is restoration of the lower complex of the periocular aesthetic unit formed by the eyelid, the cheek, and the lateral canthus. And this whole single unit plays a major role in the appearance of the entire face, as I said before. So you want to kind of go from here to here by fixing all the things or correcting all the things that we spoke about before. So what's the strategy? Well, what's my strategy now in 2022, 2023? And it's changed, and who knows, in 5 years it may be different, but I've had some good success. It's basically three things. What I call structural lift, which is a point of maximal lift, or what I call a G-point. Central support, and smoothing the transition zone, which is the nasojugal fold between the eyelid and the cheek. So what I do, so here's a young guy, a young man. He must be, 32 or 33. But this is obviously genetic. You can see he just looks tired, a lot older than his 32 years of age, and he wants something done about it. So what would you do with this? I mean, fillers are not going to do the trick entirely. He's got a lot of sagging, a lot of extra eyelid skin, tear trough deformity, and so what I do now is I do what I call a skin pinch technique. And I've been doing it for the last actually 10 years. It's a technique that I learned from a really good Tunisian oculoplastic surgeon who I met about 10, 15 years ago, and he was doing this back then. In any case, my whole kind of objective with lifting the eyelid skin is basically reducing the eyelid scleral show, fixing the lateral corner, fixing the bags, and fixing the hollows. Now you can see here, what have I done here? By just simply lifting and pinching the skin up, it corrects what he's looking for, without the danger of taking fat out and getting skeletonization. He's a young guy, he's 32 years old, he has a whole life to live. You take fat out, where are you going to replace that? I mean, you sentence him to a life of fillers, right? Basically. There's a bit of skin at the end that I'm taking out, but it makes a big, big difference. So what I do with all my patients for lower lid blepharoplasty, and there's a video here, let's see if it works, is I see them preoperatively, and I do a little skin pinch there to see whether, how much skin to excise laterally, okay? And that's when I make my marking, and I start my surgery. So what I do is, once I know how much skin to excise, I mark it. And this can be quite large. Sometimes I've gone down to 1 centimeter of skin taking out laterally. Obviously, I have them open their mouth and look up. Why? Because that stretches the skin. So always, even intraoperatively when I'm operating, I say, listen, open your mouth, because all my patients are awake. I do them under Ativan and local anesthetics. They're all awake. I have them open their mouth, look up, and that stretches the eyelid skin, and that's how I guesstimate not to take too much skin off. And I don't think in 20 years I've ever had an eyelid retraction. I've seen a lot and fixed a lot, but I've never had my own patients have eyelid retraction, knock on wood, and that's been about 20 years of practice. So because I'm very anal retentive about making sure I don't take my skin off. So basically I mark this on the side, and this is him only a week post-op. Now, it looks like it's been too much. He actually has chemosis, which is pushing the eyelid out, and it looks like it's retracted. And I'm just treating the chemosis. And chemosis can sometimes happen in the lower lid blepharoplasty that eventually goes away. But that's only a week out. Okay? No fat was excised here. So basically, looking at the process, again, what I do is I do in most patients, of course, as any surgeon knows, you vary it, right? I mean, it's not etched in stone where you do the same thing for every single patient. So I will do transconjugal fat repositioning, when I can in some patients, or I'll do it subcutaneous or transcutaneous as well, okay, with ligament release at the inferior orbital rim. I will do a mini pinch skin excision, which I just showed you, and an orbicularis suspension. This is another patient that came in. Again, you can see her problem, she's about 55 years old, a Vietnamese woman. You can see her main problem is her left eye is kind of okay, but her main problem is the skin descent, right? And again, in Asians, you have to always be careful not to take too much fat out because they need fat more than anybody else, okay? Because that's, I mean, the Asian eyelid anatomy is quite significant. It's quite different than Caucasian eyelid anatomy. So this is just, I'm not going to go through the entire video. This is a transconj, sped up, of course. I don't work this fast. I wish I did. My mentor worked this fast, but I don't. But basically, transconj approach, okay? What I start with, where I go all the way down to the rim. This is my fat repositioning. I just want to show this to you just so you have an idea. The purpose is not to teach you how to do fat repositioning, but just to show you what's involved. I basically take my central fat pad and I reposition it at what I call the G point, which is like if you form a V from the medial to lateral canthus, that's where I kind of give my eyelid the support. And not only does that give the eyelid support, it also lifts the eyelid up and works towards eliminating that tear trough deformity. And I usually use a 5-0 vicryl suture and I bring it out to the skin once I reposition my fat above the periosteum suborbicularis. So I'll skip this. And so this is just ligament release and fat repositioning. And it gives it a volume and lift. And you can see, so then what I do is once I've done my transconjunctival fat repositioning, which increases the risk for chemosis, by the way, but in any case, I do my skin pinching. So I've already pre-marked this. I kind of grab this. Again, I have the patient open their mouth, look up, so I'm not taking too much skin out, and then I cut the skin, okay, and then I lift it up. And unfortunately, I couldn't get a video for this, but I mean, you can appreciate how the whole lower eyelid region advances upwards, okay? Now, the amount of skin excision really depends on the patient, right? Depends on how much you want to excise, how much the patient needs, and it's basically a direct measure of the relationship between the patient's lid and the cheek. And sometimes I will extend it across the subciliary line if I need to, but rarely. This is somebody else's patient, not mine. Don't do this. Not every patient needs skin to be excised, right? And somebody's excised this here skin, leaving a big scar, okay? So just be careful. So then I do my orbicularis suspension. And if I'm not doing a four-lid eyelid blepharoplasty, I will still make an incision in the upper eyelid, and I'll just let the patient know that's how I do my lower lid blepharoplasties, and I'll make a little small cut in your upper eyelid. And I basically take a 5-0 vicryl suture. I grab the orbicularis and I bring it through my upper eyelid blepharoplasty incision. I grab periosteum or the bone of the superior rim. I've got 2 talks. The second one's on fillers, but Dr. Khan has already spoken on a lot of the bulk of my talks, so I'll keep on going. And they're back to back.
You can continue.
Yes. So basically, I take my 5-0 vicryl suture and I take my auricularis. This is a double arm suture. If it's a single arm suture, you can work you can work backwards. I grab a periosteum bite of the supraorbital rim, and I do it from both ends. And you can see the eyelid going up. This is not as dramatic as others, where you can actually have the eyelid go completely up. And this is actually very easy to do. It's simple, it's easy. You're not taking any fat out. You're not taking a lot of skin off. So it's a very simple, almost a no-brainer. You can't go wrong with this approach per se. And of course, I titrate. I mean, obviously, positioning is very important. Angle is very important. So basically, you know, you want to make sure that you're lateral, okay? I mean, you know, because the eyelid has to go up this way, right? Oblique. So make sure you're oblique. That's important. And you can even sit the patient up and kind of see how much you want to tighten the eyelid. But it's a really simple thing to do. And like I said, if you're not doing an upper lid blepharoplasty and you're just doing a lower lid blepharoplasty, you can make a small incision in the skin. And you know, the upper lid never scars, as you know, so it should be fine. Here are real life patients with no fat incision, just some fat repositioning, and my orbicular suspension and my skin pinch. Okay. Another patient with no fat removal, okay? Just a repositioning. What I'll sometimes do is I'll what I call fat sculpting. I'll cauterize the fat, right? But be careful, you can over-cauterize the fat and it just retracts down and you get that skeletonization. But I will cauterize the fat. I'll even cauterize it over the septum so it shrinks things up. So I'll do that as well sometimes, but I'm still not removing the fat, okay? And again, just some really good results. This is a recent patient of mine. And again, she's 55 years old, 56, never had her lips injected, by the way, and she's 56 years old, so great volume. There is some genetic factors when it comes to aging. But you can see here, she was very unhappy with how her eyelids looked for about 2-3 months. This is her about 3-4 months later. I always tell patients, listen, your dark circles are there. I can minimize them, make them look better, but I'm not going to eliminate your dark circles, right? Just so that expectations are solid. You can even treat festoons with this kind of procedure. This is a younger patient, okay? This is actually a young patient that came in probably about 26 that had these genetic dark circles, and we did the same kind of procedure, and you can see here the difference. The dark circles have not gone away, but her eyelid looks much better. So in conclusion, I always say keep it simple and use common sense. Just be careful. I think the lower lid blepharoplasty is a wonderful procedure that works really good, but you gotta know what you're doing. So please have some experience. Talk to colleagues who have done this before you get into the lower lid blepharoplasty. Thanks.
Thank you, Dr. Yasser, for that elaborative.
I mean, I had a filler, but I think we discussed everything with a. I think you spoke about everything that I really had to speak about. So we can probably open the floors up to questions. But again, I will emphasize, as Dr. Khan, Dr. Azim emphasized, with just fillers, is know your anatomy, right? I've seen, it hasn't happened to my patient yet, but I've seen patients with necrosis, especially with a nasolabial injectional fillers. And I have seen a young patient, about 41 years old man, with a CRAO because of tear trough filler injections. I myself, to be honest, I think fillers are great. And I'm doing more than I used to. For tear trough, I still pick my patients very, very carefully. But just know your vasculature. I think it's a skill set that the ophthalmologist can learn. I think that we're very comfortable around the eyes. As long as we know our anatomy, as long as we know how to fix, how to fix complications if they occur. Have Harananda with you and always have it ready. The one thing that I have done, which has worked really well, you have to be careful, is injecting fillers in the superior sulcus. And I'll just show you some really good results of what we as oculoplastic surgeons can do with fillers. Here's a young man who has, what do you notice there? What's wrong with him? It's his right eyelid, right? So you can see here, it's basically, you can use fillers for correcting lid pre-symmetry, because that's basically what his main problem was. And I think, the rest of the talk is actually very, very similar to what Dr. Khan gave, but I guess we can open the floor to questions, and if anybody has any questions about fillers or things like that.
Do you do fat repositioning for the treat of deformity?
I do, yeah, absolutely.
Is that the middle fat that
yeah.
you...
Yeah, I find that kind of gives you that lift, and then it's amazing how, and you'll experience this because you've done so many of these. It's amazing how you can fix a tear trough deformity by just pinching the skin up like this, and it all disappears. And what we're doing with the G point, the V there, what we're doing there is just giving that lift that I've done support and giving some volume there. And it works really easy, and I just like to keep things simple because, most of us have never been happy with our lower lid blepharoplasty. We're always developing it, right? Always changing it. But I've been very happy with how I've been doing it now, and that's all I do basically. I've really changed how I do things.
Do you have any questions from the house?
Beg your pardon?
Just one comment is that I think you're talking about this lateral pinch, skin pinch, and that is actually exactly in conformity with what Dr. Azim said, that the tissue by aging goes down and medially. So you're actually doing the reverse to neutralize that.
Yep.
So
No.
that's
Very good point. Absolutely, 100%. Yeah.
That's exactly the aging vector. So the aging vectors are downward and medially. So whenever we do even the facelift, you'll see horrible facelifts when we do vertical or horizontal. If we do it in a tangential way, upwards and backward, everything works better.
Yeah. That's the basic principle. Yes. Thank you.
क्वेश्चन डॉक्टर अजीम प्लीज जो डीप फिलर है कितनी देर बाद रिपीट किए जा सकते हैं?
Usually, depending on the filler, but most of the companies, they claim that they last for about a year, and which is true. So anywhere between, I would say, 8 months to a year. Some of the fillers can last up to 1.5 years and so on and so forth, but some of those fillers which I do not really recommend for around the eyes especially, are the calcium hydroxyapatite and stuff like that, which can make granuloma, because these are calcium-based fillers which have the microgranules, which will initiate the collagenesis truly. But the problem is that around the eyes, you cannot afford even the smallest granuloma because the skin is so thin, it will show up. And secondly, because of the intravascular complications. So those fillers can last up to, we use it in AIDS patients where a lot of cheek is hollow on the hands actually. But for the most fillers that I would say with the hyaluronic acid filler, around 8 months to a year.
I mean, I'll just to add to that is that, so first I really think that especially now, fillers are fantastic, and with the population here, and I really think that ophthalmologists are uniquely situated to inject fillers, so learn, obviously get that training, number one. Number two, my advice would be never, ever, ever use anything that's permanent, ever, ever, ever. Because I think there's a picture I skipped through. There's a lady that had filled, that remained, and I have operated on 3 patients from Jordan where they had permanent filler used and had wicked inflammatory reactions. And I went in there and the filler was everywhere. And you have to take it out and things like that. So yeah, never use permanent. And usually in my experience, at least the ones I use, by 1 year they're gone, which is great. And this is, yeah.
And there is a reason for that also. I usually tell patients that the permanent filler means permanent improvement or permanent deterioration. So you don't want to fix something permanently, but you don't want to deteriorate permanently also. The second thing is that your anatomy of the face changes after every few years. So you don't want to have filler sitting up here while the rest of the face is hanging down. So as you age, your filler requirements will change. Sometimes just using a few drops over the bone, for example, malar eminences, can actually give you much better result than using it in the tear trough, as you have just mentioned. So we use not in the tear trough sometimes, we use it in the malar eminence. So as Dr. Yasir said, so it's just like another trick to stretch the skin upwards and backwards.
Thank you very much. I request Dr. Aisha for his comment.
I think that's the end of the discussion for today. Well, thank you so much, Dr. Yasir, and thank you all the speakers who have been here. It's been very informative, and I think very unique things have been added as well, especially as related to the lower lid blepharoplasty and what Dr. Azim also had us imparted to us. Because these things sometimes we do know, but we tend to forget about them, or they don't become important really anymore. But revising all of that, it really helps us to further, be careful when we, going ahead with these procedures. So I thank all the speakers here and all of you who have come here in great numbers. And please enjoy yourself.
Thank you very much.